Morning. In fact, 6 years ago, I was like all of you sitting here and enjoying the lectures of this workshop. I've been working in the Prince of Wales Hospital for the last 5 years, and I have found that the preeclampsia screening is so useful and amazing, and therefore I'm really delighted to be here, to be the co-host today, with the opportunity to share with you about the uterine artery Doppler used in the first trimester preeclampsia screening. There is now substantial evidence that the first trimester combined test of maternal factors, measurement of the uterine artery Doppler, mean arterial pressure, and serum placental growth factors achieve excellent prediction for early onset preeclampsia with detection rate of 90% and a false positive rate of 10%. And the detection rate for preterm preeclampsia and term preeclampsia is around 80 to 47% respectively. This slide shows the different combinations of biomarkers and their detection rates at fixed false positive rates of 10% for the detection of preterm preeclampsia less than 37 weeks. The best combinations is, of course, the combination of mean arterial pressure, the uterine artery PI, sorry for the technical error. So let's try to reiterate a bit. So the best combinations of detection is the combination of mean arterial pressure, the uterine artery positivity index, and the measurement of the PLGF with the detection rate of 76%. And in fact, you can see actually a model that combines the maternal factors with the mean arterial pressure and the uterine artery Dopplers already achieved a very decent detection rate of 70%. So despite seeing relatively good results with a combined prediction model, there is still a lot of debate on the utility and applicability on the measurement of the uterine artery positivity index. The next few slides will cover the techniques that have been endorsed by the FMF as well as the ISWO. In the first trimester, we are advocating for the measurement in the transabdominal ultrasound approach. The way to identify the uterine arteries is to firstly apply the transducer longitudinally over the suprapubic area here to obtain a sagittal section of the cervix, and then use color Doppler, fixing the probe in the midline of the cervix, and you will see the endocervical canal. And then you should slide the transducer, tilt it to the sides, and identify the uterine arteries at the level of the internal os, as you can see in the middle picture. So usually I will make an imaginary line there at the level of the internal os so that you will know where to put the cursor at. So adjust the sampling gauge to 2 millimeters to cover the whole vessels and ensure the angle of installations of less than 30 degrees. Well, as this slide is really important with the techniques of the measurement of the uterine artery. So I will, because the Zoom audience may not see the slides properly, I will try to repeat again for the measurement of the uterine artery. So you can look at the slides here. So we will put the transducer at the suprapubic area. And usually we will get a sagittal plane and to try to find the whole cervix. And find the midline of the cervix is also important. We need to see the whole and the cervical canal so that you know it is the middle of the cervix. And so after identify the cervical canal, you can tilt the probe to the sides, and so that you can find the uterine arteries at both sides of the cervix. So remember to turn on the Doppler in order to find the uterine arteries, and make sure the sampling gauge is adjusted at 2 millimeters to cover the whole vessels, and ensure the angle of installations of less than 30 degrees. So you will obtain the waveform as seen in the bottom picture here. It is important to check that you have indeed sampled the uterine arteries. So to check, you need to make sure the peak systolic velocity is more than 60 centimeters per second. You measure both the left and right uterine arteries, then take an average of the two for the risk calculation. The Doppler settings are adjusted as follows. The pulse repetitive frequency of the current Doppler should be maintained at between 3 to 4 kilohertz, and the scanning speed is adjusted so that there are 4 to 10 waveforms on the screen, and the PRF is adjusted so that the size of the waveform occupies 50 to 75% of the scale, and a low-pass filter should be used. The power is maintained at 100% because the thermal index for soft tissue was always less than 0.5. So in the graph on the right, we have plotted the uterine artery PI in form of the preeclampsia cases against the gestational age at the delivery. First, it is clear that the women who are destined to develop preeclampsia have higher uterine PI at 11 to 13 weeks. And you can see most of the dogs is about 1 month there. And there is a negative correlation with the gestational age at delivery. So the higher the uterine artery PI at 11 to 13 weeks, the higher the chance that early onset preeclampsia may set in. As you all know, during the second trimester, we measure the uterine artery PI at the crossover with the external iliac artery. Many of you have asked, where should we measure the uterine artery PI at 11 to 13 weeks? Should we measure the uterine artery PI at the crossover with the external iliac artery? However, as shown in this study, sampling sites at the level of the internal os appear to be more reliable. Site A in the top of the picture is sampling at the level of the internal os, and site B is at the bottom picture, is sampling at the crossover with the external iliac artery. So compared with site A, the PI measurement at site B is lower, and you can see in this graph. And in this study, the investigators also repeat the uterine artery PI at mid-gestation, and using the conventional approach where sampling was done at the crossover with the external iliac artery. The graphs on the right shows the first trimester uterine artery PI, which is here shown with the front black line. There is a better correlation with the second trimester PI when the sampling was done at the level of the internal os. The last point relates to the fact that satisfactory measurements were obtained in 100% of women when it is measuring at the site A, but only 62% at the site B. So it makes the sampling more easy when we are sampling at the internal os level. Another study has demonstrated the importance of sampling sites for the measurement of the uterine artery PI. In this Australian study, in each participant, the uterine artery PI was measured at the level of the internal os and also at 3 centimeters distal from the os. The authors has found that the distal PI measurements were 50% lower than that obtained at the level of the internal os, shown here. And the same finding was also observed in the measurement for the peak systolic velocity, which is the PSV, and which is an important marker to determine if whether the vessels sampled is not the uterine artery. 60 centimeters per second has been determined to be the 10th centile, so that the PSV is below, if it is below 60 centimeters per second, it is highly probable that the PI is not of the uterine artery. We have also evaluated the importance of sampling location. In this study, we aim to investigate the difference of the uterine artery PI between different ultrasound doctors and different sampling sites, and the influence on the detection rate of the early onset preeclampsia. We recruited 58 pregnant women with the gestation age between 11 to 13 weeks. The uterine artery PI was measured by an MFM trained expert, which is A, and another fetal medicine expert, which is B. Let's look at the figure in the middle. The black bar here belongs to the sonography A, and the gray bar belongs to the sonographer B. You can see that the uterine artery PI measurement at the internal os by the sonographer B was lower than that of the sonographer A. And sonography A also measured the uterine artery PI at 1, 2, and 3 centimeters distal from the internal os. And you can see the sonographer B's measurement, in fact, corresponds to the 2 centimeters distal from the internal os of the measurement by the sonographer A. So sonography B is likely that persistently measuring the uterine artery PI at the wrong sampling sites. So there is a risk of reducing the screening performance of the preeclampsia prediction algorithm, as shown in the right figure. The detection rate is estimated to be reduced by 8%. So to conclude, the measurement of the uterine artery PI is affected by the sampling sites. And despite a prescriptive measurement protocol, there may be still significant difference between ultrasound examiners. So there has been a lot of discussion with regard on how we should evaluate the quality standards of this ultrasound marker, just like the measurement of the NT for the screening of Down syndrome. So audit is very important. This study, the authors evaluate the effects of audit and feedbacks on the performance of the first trimester uterine artery PI measurement. It is a prospective cohort study with around 2,500 singleton pregnancy, which is measured by 12 operators. Individual sonographer CUSUM and target charts were generated to assess the central tendency and dispersion to identify systematic measurements of errors and deviation from expected measurement performance. 6 operators received regular feedbacks, while the remaining 6 did not receive any feedback. The group that received feedbacks performed better than those received none, with a screen positive rate of only 4.3% in the group that have received feedback, and the performance is the SPR is 6.8% in the no feedback group. And also ideal central tendency and dispersion was observed in 83% in the feedback group, but only 58% in the no feedback group. The middle diagram is target charts that shows individual sonographer central tendency and dispersion according to the feedback groups. So dots are the feedback groups and the square are those with no feedback. So with the central tendency on the x-axis and the dispersion on the y-axis. The inner rectangles represent 5% of the expected median of 1 month, and the outer rectangles represent 10%. So the top CUSUM plot charts belongs to a sonographer who have received feedbacks, showing the correction of the central tendency over time, whilst the bottom CUSUM belongs to a sonographer that did not receive any feedbacks. And it is clearly shows that the sonographer here clearly consistently overestimate the PI with no adjustment of the technique. So CUSUM and target graphs are effective methods of audits for the first trimester uterine artery PI. Feedback to operators are also very important, resulting in improved measurement performance, which will ultimately improve the screening accuracy. We have also introduced an alternative method to measure the uterine artery PI. The purpose of this study was to compare the uterine artery PI measured by the sagittal section and the transverse approach by an experienced and 3 inexperienced sonographers. So but the method of measurements and the order of examiners were on a random basis. Consistency and reliability were evaluated by ICC, the Glenn admin methods, and passing method regression analysis. So the transverse technique is described below. So we will use a low frequency trans-abdominal probe with a sagittal wheel, using a sagittal wheel first with the internal os identified. And then With the internal oars put in the center, we will turn the probe to 90 degrees. You can slide the probe slowly up and down using the shadow of the cervix as a guide to confirm the sites of the internal oars. Color Doppler should be applied to visualize the uterine arteries, which will appear on both sides of the internal oars here. The FMF criteria is used to sample the vessels. For the experienced sonographer, there is no significant difference between the uterine artery PI measurements using the sagittal and the transverse measurement methods. Passing blackboard shows excellent linearity, and the ICC is also very good at 0.921, and Van Edman shows that the difference between the two methods is very low at 0.01. For the inexperienced sonographers, there are also no significant difference in the uterine artery PI measurements using the sagittal and the transverse measurement methods. The passing blackboard shows excellent linearity, and ICC was also very good for all the three inexperienced sonographers. And Van Edman shows the difference between the the Van Edman shows that the difference between two methods was also very low. One is negative 0.1, and the other is 0.04, and the third one is 0.03 for the sonographer A, B, C respectively. So the time required for the measurement of the uterine artery PI using the two methods were also similar. However, currently, we do not recommend using the transverse approach in replacement of the sagittal approach for the routine measurement of the uterine artery PI. However, this alternative approach might be helpful if you struggle to measure the uterine artery PI by the sagittal approach. So this video shows the measurement of the uterine artery PI through a transvaginal ultrasound scan. Here are the steps. We empty the uterine bladder and the urinary bladder with the patient placed in a nephrotomy position. We first obtain the sagittal plane of the cervix, as shown in the diagram, and we will use the color Doppler to identify the vessels. Gently move the probe to the lateral fornix so that you can identify the uterine artery at the level of the internal walls. So the sampling approach is also as per the FMS protocol. Many of you may wonder if you can measure the uterine artery PI with the transvaginal scan. So please take a look on these graphs. The left graph shows the relationship between the uterine, the transvaginal and transabdominal approach. When the uterine artery PI measured by the transabdominal approach, which is high, when it is high, the difference between the two methods is greater, as shown in the area here. And this may lead to an underestimate of the uterine artery PI, and so leading to a false negative valuation. So it is important if you wish to provide the first trimester preeclampsia combined screening, then you must ensure you are accredited for the measurement of the uterine artery PI. We can use this with the FMF website as shown here. On the website, you can also use the risk calculator free of charge. We have also developed an app so that you can calculate the preeclampsia risk with your mobile and cell phone. At the Chinese University of Hong Kong, we have also established a preeclampsia risk assessment service. Our program also allows quality assessment of the biomarkers, including the uterine artery PI. Let me show you two examples. These reports belong to a sonographer who has performed 234 measurements of the uterine artery between a period of August 2019 to February 2022. The target plot on the left shows that the observed median is within 10% of the expected value, and the Poisson chart shows good measurement results very close to the expected median value. Another examples belong to more reports in the past, because recently the sonographers have been doing very well. And I take examples of this because it indicates that at the very beginning, with the measurements, after just 37 measurements of the uterine artery PI, the target plots show that the observed median is outside the 10% expected value. The cushion shows that the sonographer tends to overestimate the uterine artery PI, but he or she has been constantly adjusting. In this case, we would advise to continue observing the quality assessment data. So in summary, here shows some tips and tricks for the measurement of the uterine artery PI with the transabdominal approach. Try to keep the probe in the midline plane with the endocervical canal observed, and slowly tilt the probe, not to really slide laterally. We tilt the probe to the size of the cervix to identify the uterine arteries. And in most cases, the first appearing most colorful dropper signal representing the uterine artery. So as Professor Poon also mentioned, beware of the uterine contraction, because sometimes it will lead to an absent end diastolic flow, and which makes the PI higher than the actual value. So you must repeat the measurements after the contraction subside. You can measure the uterine artery PI from either the descending or the ascending branch. And the uterine artery PI can be sometimes difficult to measure in Paris women and in those having a cesarean section. Sometimes the uterus may be tilted or angled, so that it may be a bit more difficult to find the uterine artery. And if you are struggling and unable to identify the uterine arteries by the sagittal approach, please consider the use of the transverse approach. But this method is not to replace the sagittal approach. That's all for my sharing. Thank you.